Good morning, everybody, and welcome back to the Happy Hearing podcast. I am Dr. Ruth Reisman, a professor and audiologist here in New York City, and I am here again with my podcast co-host, Carly Sygrove. So, Carly, take the floor.
Hi, everyone. Welcome to episode 9 of the Happy Hearing podcast. I'm Carly. I'm a hearing loss coach and hearing health advocate and writer. And we're joined today by Natalie Stephenson. And Natalie is a London-based audiologist who works for the NHS. She provides hearing care for adults with learning disabilities, adults with dementia, and children. Natalie's area of passion is how we support those who perpetually fall through the cracks, who for their hearing needs, such as those with learning disabilities. So welcome to the Happy Hearing podcast, Natalie.
Thank you for having me, Ruth and Carly. Appreciate it.
It's great to have you here.
Of course, it's great to have you, especially from all the way on the other side of the world, at least in reference to New York. But I was really interested about your background and your focus on advocacy for those individuals that kind of, fall through the cracks, so to speak. So if you can speak a little bit to that and what the dynamic is in the UK and what you're doing to try and help increase that awareness and help these individuals.
So I would say that there's a group of people who often have been overlooked in terms of equity and accessibility. So you've mentioned those with learning disabilities, and for your American audience, that also translates to adults with intellectual disabilities. So we use a different term, but we're encompassing those people who would require support because of a cognitive impairment or born with something which means they need extra support. So you've got a population of people who maybe have been used to having carers, been used to being in schools of where there are, where their special needs are met. And often when they become adults, there's a lot of stuff around the pediatric side when they're younger, that kind of under 18 or under 25 in this country for people. But when people hit above 25, it can become a situation where people are kind of left to the kind of, they're not, the targeting isn't there as much, and it can depend on where you live. And so by targeting, I mean, for example, hearing. So for my domain, it's hearing. And my experience of working on a community team where we could actually and actively go out into the community to people's homes, whether that be their home that's a supported living or a care home, whatever type of home setting that they were in, it meant that you could go directly to people who were not necessarily housebound, but were homebound for many reasons. People who perhaps hadn't been out for many years. I came across clients who hadn't been out for many years and who were receiving what we call over here domiciliary care. So people, services go into them to offer different types of health care and therapeutic care. So occupational therapy, physical therapy, physiotherapy in the UK, the term we use, and nursing. And so there was that going on, but hearing has always been, I almost feel like a poor relation in terms of people's needs. So people's needs, acute needs, are met quite quickly in terms of like anything to do with respiratory or anything else, but hearing and vision seems to have been sort of okayed. But for hearing needs, you often finding people who can't necessarily express that their hearing is going in the same way that we would realize those nuanced differences in our hearing. And because of their intellectual disability, or their, if you like, sometimes they're not being very verbal or completely non-verbal, there's often, I experienced the idea that people think that they are okay because their benchmark is set slightly lower. So people aren't realizing actually this person's not hearing, that's why they're not participating, or that's why they're not, they've gone into themselves a bit more, and because of their decline in hearing. And it's kind of overlooked. It was overlooked a fair bit. Some people get it really well, and other people don't understand it at all. So seeing clients who perhaps they're nonverbal, perhaps they are not going out. So the experience of a hearing loss when you're in background noise is where most people realize, oh, actually my hearing's going. But if you're somebody who's in a quieter environment, you might not pick it up. And if you're somebody talking to and engaging with somebody with a learning disability in a quieter environment because you're caregiving or you're a support worker, you may not notice that your person's hearing is subtly changing and that they need that support. And so the delay in getting help is kicked off because nobody's coming to them to check, and they're not seeking a checkup. Right. And so that was obvious. The biggest thing that was obvious was the amount of wax needs that this population has. 9 out of 10 of every visit I did required a significant, required first-line wax management through an olive oil use. But then even that wasn't adequate, because invariably you've got a population perhaps who have Down syndrome, who anatomically, smaller ear canals, small amount of wax causes a significant blockage, doesn't take much. And then you've got a population of people who would need more of a, I would say more of a experienced person to do the wax removal, because at that point we weren't delivering wax removal in the community in people's homes. So then you've got a waiting game where you're kind of having to remove wax before you can even carry out a full assessment. And as I said, 9 out of 10 were experiencing impacted wax, which, you know, in the general population, you know, we can go and we can seek help by getting some wax removal support. But as I say, in that population, you need somebody who's much more experienced, because also you've got people going in for wax removal who might be more anxious about that. The experience, it can be quite overwhelming. So it's not as straightforward as, oh, let's remove the wax and let's kind of get on with it. You need people who have an understanding of how to communicate and how to, you know, treat somebody that just needs that extra bit of time, extra bit of care. It's not an in and out situation. So that was one thing. And it was kind of more so that we know that caregivers overestimate the level of hearing that the person that they're caring for has. So because you're in close proximity, because invariably the background noise is quieter, people will say, oh yeah, they can hear. Oh yeah, they're fine. And then you right. do the kind of questionnaire about kind of functional, how are they getting on functionally day to day? And you then start to unpick those questions. So it's when you're talking with them, what is the, you know, how does that communication exchange go? Is it just a yes or no answer? Or does that person even have the capacity to answer? And what's your benchmark for them hearing? What does real hearing in a person look like who cannot express that they can't hear? And often what we saw from this, what you see from the studies and what you see on the ground is that people are thinking that somebody can hear well, when actually you do a hearing test and you realize actually they're not picking up on certain sounds. And if you factor in background noise, additional auditory processing, which is what happens again in more affected, more present in this population, is the auditory processing. There's a longer, you need to wait longer. You need to give people time to understand what's being said to them in order for them to compute, for them to form a response. And so it's that being a conscientious communicator with somebody who has additional needs, and having an awareness of what difficulty looks like in somebody who can't speak or who can't articulate. So another area would be somebody with an ear infection. I was coming across people with active ear infections who were non-verbal, who were not displaying. If what I saw, that person, you or I, would have complained to our doctor and said, it's painful. There's that I could, it would be quite an excruciating situation. But when somebody's non-verbal, what became apparent to me is how do we know what pain looks like in somebody who doesn't express, who is non-verbal? Because I came across a lady with an active ear infection who was chronically mouth breathing because of the anatomy, probably something going on with the adenoids as well. And she was soundly sleeping, but yet I looked in her ear and her ear had an active smelly discharge. So by all accounts, that woman would, if had she been able to express, would have expressed some form of discomfort at the very least. And that should have been obvious, but it wasn't. So then the question is, how are we gauging pain, discomfort in people who are not able to articulate pain and discomfort, and who have become used to a certain level of discomfort?
Right.
And so that was obvious to me, that people's experiences in terms of things they become used to, become desensitized to, were quite was quite eye-opening for me. Things that we would have raised as an issue, people's bodies have become used to, and perhaps because they can't articulate so as readily, it was being overlooked, because unless you had an otoscope, you wouldn't have known that was going on. And again, it comes down to how frequently are we checking people who are not going to actively seek support.
Yeah.
So that's where we have to then consider and factor in, okay, we might need to be more proactive with monitoring, with ensuring that, again, these people don't fall through the cracks because we haven't checked. We can't necessarily wait for people to say that they need help.
Yeah, I think it's like a worldwide epidemic, unfortunately, because even in the US, right, we have early intervention, we have intervention in the school system, and then, like you said, for those with special needs, and hearing, even a hearing screening is not part of the protocol. They're not even, audiologists aren't even part of the therapy team, which is very disheartening in a way, because like you said, how can you go on and do speech therapy without having ruled out a hearing loss, an auditory processing disorder, even if hearing is normal? And okay, if you don't want to send an audiologist to every home to rule that out, because maybe that's not efficient, we are a small field in general and maybe don't have that manpower, but someone at the very least, whoever's doing the initial intake, should be doing a hearing screening. Like you said, look in the ears, ask the questions, because otherwise we're missing so much. And to that point where you brought in that example of the woman who has an active drainage from the ear, and people might say, okay, we'll give her antibiotics and so on and so forth, not realizing the sequelae that can lead to, and how that could potentially even impact, God forbid, her brain or the bones or whatever, and then lead to a much more severe disorder that could have been avoided by doing a simple look in the ear or a hearing screening, and then determining whether they need some sort of therapeutic help. But like you said, even other things that are connected to it, whether it's auditory processing, balance, cognition, that are all being found to have direct connections, direct correlations to someone's hearing health, are not even taken into account in this population, in the pediatric. I mean, I'm pretty confident to say in nearly every population, which is just a little sad in a way. And I think it should be something that's part of the regular screening process.
Yeah, and I agree. I mean, because of the team I worked in, what I was able to see is how how great it is when the modalities come together. So you mentioned speech and language. So these were adults, but then in the pediatric population, you're seeing children going through, one of the gatekeepers is audiology. So if there's a speech delay, they will request an audiology referral so that we can check hearing. But again, we're just checking hearing. We're not checking processing as a kind of a default. So you can have you can have a perfectly working hearing pathway, but then what happens between the end of that pathway up at the brain level is completely different to what a hearing test result could give you versus what a test of how somebody is processing that sound. So using speech testing and speech and noise, again, isn't part of it either. So it would just be a straightforward hearing screen, a middle ear check to check for fluid, a visual check, otoscopy. So again, you're missing out. There are parts that are missing. And being an MDT that I was in, particularly last year, means that somebody can come to you from a different modality and say, what was this result for that? What were they doing with that? Like the sensory stuff with the occupational therapy team, supporting somebody with who has, phonophobia, or somebody who just, because one of the default things that I was finding as well in peds was sometimes parents were being told to give ear defenders for children who were finding outside too much. And that kind of can have it can be counterproductive because if they're overused, that child's sense of what is normal in terms of normal volume levels, gets artificially reduced. And it means that the real world becomes ever more problematic. And so ensuring children have a way round of being able to overcome any kind of sensory issues around sounds, having that support from an occupational therapist and working, because they can work on the sensory stuff as well alongside what you give them as an audiologist, is super helpful. But we work in silo a lot of the time. We're working as independent, like I am only checking ears. And the therapeutic aspect of our arm is, I think, not seen. Like we're seen as like scientists, which is great. We do a lot of diagnostic tests. We give hearing aids, which makes it even more technological. But we play a huge part of my role is the counselling part, is the therapeutic part, is the reducing anxieties around people's sense of what a hearing loss means and how it'll impact their life or how it'll impact their child's life. And so that holistic kind of bubble that people should be put in, which is looking at that whole person, I think we're not seen as therapeutically enough, if that's even a way of putting it, because the focus is, oh yeah, they've checked the hearing, but we've also, in our management, in our habilitation, and in our rehabilitation, it's heavily, I mean, for my mind, it's heavily counselling driven, to kind of ensure people's sense of their identity, and to empower them through what can seem potentially like a life-changing diagnosis, and to navigate people.
Natalie, you've talked quite a bit about patient anxieties, and I'm wondering, how would you adapt your approach to accommodate the specific needs of people with learning disabilities or children during their hearing assessments and treatments and this kind of thing, just to make sure that those anxieties, are as minimal as possible?
So what was clear is that there were some of the population that find the hearing test, even just looking in ears, to be hugely problematic. Just getting an ear check, going near somebody's head and ears, that's the first problem. So one of the things that I have been doing for a while, and I tend to do, is obviously with safety in place, is I will usually what I would do is say to whoever I'm going to, can you get hold of a thermometer that mimics kind of, you know, just so that it mimics like a home testing thermometer, just so that you can try and build up exposure to something going in the ear. Can you try, there's a lot of things around using earphones. So not that I'm completely not an advocate of screen time for children to any length, to be honest, but having an audio book, an audio story where it's the carrot approach, where they get used to having an earphone which sort of looks like the tip of a tympanometer, so the middle ear check tip. Just getting people prepared in advance with the type of look, giving people a Zoom call before you go and see somebody, so that you introduce yourself, so that they get to see who they're coming to, was something that I was also doing. And then when they're in clinic, one of the things I don't get bogged down with is getting results that day in that clinic. Now I know that I'm slightly outside of the park than other people's approach. However, a successful clinic visit for somebody who's hugely worried about even coming, who you probably had to effort to get into the room, is that they get used to the room, they get used to you, you let them handle the equipment, you let them have a look at it, you talk someone through it. If they require, depending on their age range, letting them carry it out, so to their significant other, letting them, and that for me is a successful appointment, so that person comes and realizes all is well here. The level of fight and flight and that kind of stress around that space can be hopefully somewhat alleviated, and they've looked at the equipment, they've understood the process, and their caregiver will go away now and reinforce that type of exposure with similar objects at home every day until we come back. And so that for me has always been of paramount. If I see a successful appointment with somebody who was freaked out by coming, that they are not freaked out when they leave, that we've got to know each other. We've built there's an element of trust from the rapport that was built, and that way there is no sense of urgency, which then increases people's cortisol response, their stress, and no, there's no sense of urgency. We've come to acclimatize. They might not understand the language I'm using. I might not even use that language with the caregivers, but it's a sense of this was successful, and I preempt, because I've got to know the person, particularly in the population I was seeing, parents or caregivers are able to know this was successful. Don't be despondent. Because some parents or caregivers leave and think, oh, but we haven't done anything. We've done a lot. What we've done is we've taken somebody who wouldn't let us near them. They've held the otoscope today. They've played around with it. We've done a light show around our body, catching light. I mean, one of the things I do is shine the light in a child's hand, for example, and they have to hold the light and give the light to their mum or their dad or their caregiver, and it just gets rid of usually that fear around the objects. So that's what I've tended to do, and yes, I haven't got results on that day that are scientific or quantifiable, but it's part of the process of building trust and rapport and ensuring that people want to come back. And that's how that's the kind of philosophy I've always taken.
Yeah, I really like that approach, because most of the time when we're working with these patients, like you said, we are building rapport, we're building long-term relationships. The goal is that these individuals will be coming back to get their hearing checked every 6 months or every year, depending on whether they need wax, management, things of that nature. And I think that's really a great approach. I'm even going to take that light activity and do it with the kiddos that we see in the clinic, because I think that's really sweet. But to one of your points, I think the biggest point of advocacy is making audiology or hearing a standardized portion and follow even within the annual follow-ups, because like you said, let's say a child can come in, or a newborn, right? They can get screened, their hearing, they pass the hearing screening, then they can come in, let's say, before they go for their SLP evaluation at 3 years old or something, get a hearing test, hearing is normal, but we still haven't assessed auditory processing, and at no level have we looked at that aspect even. And then that can come again later on at 7 years old or 8 years old, when they're now having issues in school. And between 3 and 8, we have done nothing to assess their hearing, whereas we could have maybe identified them with an auditory processing challenge at 5 years old and have done a lot of rehab before they've reached the age of 8, and make them much more successful in the school setting.
Yeah, absolutely. Absolutely. And I think, as you said, until we're at a point where we are like literally as standardly doing what we would consider the bread and butter, which we're not quite there yet. From a newborn stance, particularly in UK, America, Australia, and other countries around the world, we do have a newborn hearing screen, which is great capture. But again, we know the importance of that, and we know what that's gone on to do for children. And that's not to take away anybody who uses signing as a communication modality, but for families where they wish to seek hearing management intervention, the newborn hearing screen has been a success, but it's not everywhere for everybody yet, despite what we know of how important and what it can do. So it's just those challenges of where who's advocating on behalf of audiology for it to become something that is enshrined in standardized workups at opportune times, throughout, from birth, in the early years before school. It's just having that awareness, because the increasing glue ear is huge. I'm seeing more and more children. It's lasting longer. It's lingering. The mouth breathing is very significant, which we know is not a healthy way. You can breathe by your mouth, but it's not the healthiest way to allow air into the system. It kind of can, it doesn't support the health and the well-being of the structures within the face area, within the throat. So we've got a situation where, especially, I don't know about America, but in the UK, we've got more and more children with asthma presentations. So it's kind of all of these things kind of linking up, and how are we keeping on top? Because we know that when a child has glue ear, their hearing can fluctuate. So how are we then able to then support that child when that child is chronically blocked up? Ears are experiencing middle ear fluid. What do we do, and how can we best support that child? Because then we know the speech acquisition is delayed. We know that concentration, the efforting when you're hearing in this way, and the behavior profiles that can then manifest when a younger child isn't able to hear as well and get their point across. And it just has such a domino effect on their learning and on their social, on their whole aspect of going into school. So we do need to, I think, try to have more of a way for people to gain access. But again, that's about capacity and clinic capacity, and probably outside of the bounds of what, I don't know, is achievable. But we certainly need to be on the ball a lot more around children and hearing, and how they're hearing and how they're listening, not just hearing. What is their listening doing? How are they navigating their listening? Because there's other things that are manifesting in and around their learning, in terms of harder to learn things, difficulties, things that are cropping up. So yeah, there's a lot to be unpicked.
Yeah, I think you bring up a lot of really great points. It almost seems overwhelming in some ways to get this information out. But maybe to kind of tie all the ends together of what we discussed today, you know, what is one thing that you would suggest as professionals, as hearing care professionals, audiologists, that we can do today to get more of the word out and try to help more people?
I would say one of the key things we can do is to become more, on a personal level, more self-aware of our hearing, of subtle changes, and just have that self-care approach to getting on top of, okay, that's something, you know, I was hearing that before, or don't try to muddle through. I would say to try and empower yourself through any barrier that might be there, that's real or perceived, around seeking a hearing check. I think it's a fundamental aspect of just taking yourself on board and seeking out a hearing check. And also for other people, I think hearing loss has long been it's still in the butt of jokes, even in comedy, you know, like people mishearing, you get those mishearing jokes that still crop up in people's kind of and it's also people's irritation when, you know, I told you before, you know, it's like they've had people having to repeat themselves. And I think if people step back a little bit and become more aware that actually perhaps that person didn't actually hear me very well, or actually it must be quite difficult when you can't hear, having that awareness of what a hearing loss might look like in the early stages, and encouraging their loved ones or people that they're around to seek a hearing workup is something that is really important, so that everybody can take as much responsibility for themselves, but also you know, be accountable for others who may not be able to take that responsibility for themselves. So somebody who has a carer, who, you know, don't just leave somebody there, sort of think, hold on, when was the last time they had a hearing test? Let's go and get their ears looked at, and just being mindful to changes in oneself and in others.
And the population that you're talking about, the people who have got carers or children, these are people who may be already struggling with this communication, and hearing loss has such an impact on communication and making those connections with people that really these should be the first people getting checked, you know?
Well, absolutely. And I mean, what we know is that hearing from right from birth to end of life, hearing is the last sense to go. That has been confirmed. So if we are about dignity as well at the end of life, and dignity in general for people, then we can't miss a trick with testing their hearing, because we are giving somebody who, and as somebody who has lost a parent, who got to be with that parent at the end of life, myself, I know my dad could hear me. Now, he was in intensive care, so he couldn't, but I know he could hear me because I just know. And so, now it's been confirmed. And so having the ability to have those conversations when somebody is still with you, who may be dipping in and out of that process, is also another, we haven't covered it, but just to cover it now in terms of dignity, and making sure that when somebody goes into hospital, we don't lose their hearing aids, because that's another thing that happens. The amount of hearing aids that get lost whilst a person is in a hospital environment is quite high. It's unacceptably high. The same with in some care home situations. So it's about, are we supporting someone to be in the best position that they can possibly be in, or are we not really cottoning on to actually this is how important it is. So it is important that somebody, when they first wake up, is given, if they can't put their hearing aid in for themselves, please put their hearing aid in. It is important that if somebody's hearing tube is hard and rigid and brittle and almost at breaking point, that their caregiver says, oh, this needs to be done. You know, maybe they weren't told by their audiologist, let's change your hearing aid tube every 4 months, because that's how we get the best sound quality going through to the hearing aid. So it's these kind of housekeeping things around the importance of the hearing aid. Do you know that the hearing aid is exercise for the brain? So for somebody who's incapacitated, maybe doesn't have the level of mobility that they but they can actually, by giving them a hearing aid, you are giving someone exercise, you're affording someone the exercise and the dignity that they can be present in the space that they're in. You're not shutting someone off, you're not closing someone off. So it's about people, it's about raising people's humanity for another person, to be honest. It doesn't take very much to do that. It just takes a conscious effort that everybody agrees that if somebody comes into hospital and you know they've got a hearing loss, please don't lose their hearing aid. If you're talking to somebody in a hospital and you're delivering news and that person can't hear you, then you are not delivering news to the patient. You're just speaking at them, not with them, because that person can't then come back with a question. They can't engage in their care, in their own care, because they're not hearing as well, plus they're not well, so they're not going to be as their processing is going to be slower. So I just think we all need to like, I would say, like, hashtag hearing care in hospitals, hashtag hearing care in care homes, means that we ensure people have their hearing aid. It is a therapeutic tool. It is a medicine, in my opinion. If that person has a hearing loss and they're not a signer, then if you don't give somebody who's not a signer a hearing aid and they can't communicate any other way, then you shut them off. So we need to be taking responsibility and accountability for when we dismiss a hearing aid as just being, oh yeah, that's their hearing aid. No, it's their way in to being actively present in their life. And we shouldn't be shutting people off. We have no right to do that, especially when somebody is already vulnerable.
Yep, I love that. And I think, you know, we can end on that note to kind of say hearing matters from day one of life until end of life, which I didn't, which in all honesty, you've just changed my life as an audiologist, because I didn't even think of that perspective. And, you know, when I think of, you know, my grandfather, when he was lost, and we actually recorded, it was at a point where we can record and things like that, where it wasn't as common when I lost my other grandparents. But I remember my brother was singing to my grandfather, and like you said, you know, he was unconscious, but he was on basic life support, but his breathing was shifting when my brother got to certain parts of the song, and that kind of gave an indication that he was hearing, he was understanding what was happening. So I think that you just changed my life ever so slightly. That's going to shift my path in a completely different direction, to show the importance of hearing from day one until, you know, year, whatever, 120, whatever lifespan we have, and how important that is.
Yeah, I completely agree with you, Ruth. I think what I'm taking away from this is that word dignity. You know, people deserve dignity. We all deserve to have that. And hearing is part of that, and having connections and communication is part of that. So yeah, like, super interesting today.
Yeah. Thank you so much, Natalie. It was really a pleasure having you. And
you.
You've inspired us in a number of ways, and we really appreciate that, and wish you much success in your continued work, and let's just keep spreading the word as best as we can.
Absolutely.
Yeah,
Thank you, Ruth. Thank you, Carly.
Of
Appreciate it.
course. Thank you.
Thank
Have a
you.
wonderful day, everyone. Thank you.
great having you.
Take
Thank
care.
you.